Shock is sometimes described as kind of like a pause button on the act of dying. So basically, what shock is it's the result of some kind of physiological problem that poses a threat to cellular perfusion. Our body's really cool. The way it works, the way it's able to compensate, it can make up for a lot of things that can happen, but it's not unlimited. There is a limit to what it can do. So whenever that underlying problem, whether it's blood loss, damage to the myocardium, whatever happens, if it's too severe, then our compensatory mechanisms are going to be inadequate to maintain cellular perfusion. So when this occurs, if there is not medical intervention to restore this perfusion, that patient's going to die. How quickly? It varies. Maybe minutes, hours, maybe even days. But that patient will die. So ideally, our interventions are going to happen before cellular death starts. Sometimes resuscitation stuff may restore perfusion short term, but the cellular death that occurred before that is going to lead to organ failure and death days later. Sometimes despite having access to the best medical care right then, right there, the patient still cannot survive the underlying problem. With us being in the pre-hospital setting, we can't tell at what point that cellular death has already occurred or how much has already occurred. So we need to make sure that we're giving all of our patients that show signs of shock the best care that we can, in case that they are not to that point where you have irreversible organ damage. We want to give them every opportunity to do what they need to do. So perfusion is adequate when every cell in the body gets the blood supply that it needs to provide the oxygen and the nutrients and to remove the metabolic waste. So, for this to happen, you've got to have at least these three conditions. You've got to have adequate onloading of oxygen in the hemoglobin in the red blood cells. You've got to have adequate transportation of that oxygen-carrying red blood cell to the tissues, and you've got to have adequate offloading of oxygen for use at the cellular level. And if you're not familiar with that, there are things that can interfere with that. There is another lecture, a discussion about that. Now, in order for the cardiovascular system to provide those three conditions, the heart has to be functioning, so the pump has to be pumping. The blood vessels must have the peripheral vascular resistance, so they've got that kind of tension on them that's going to help maintain the size of the vessels. And then there has to have an adequate amount of volume of blood. Okay? If your pump's working and the container's there, the right size, but you don't have enough volume, problem. If your pump's working and if you have enough blood, but the container size is too big, you're not going to have the ability to pump very far. If your vessel's the right size and you've got your blood, the right amount of blood, but the pump's not pumping, it's not going to move forward. So any one of those three components that goes wrong will interfere and cause hypoperfusion. So shock is just a state of hypoperfusion that happens when any condition interferes with delivery of oxygen to the cellular level. And in the initial stages, we recognize shock as compensated, decompensated, irreversible usually. So these are our body's attempts to compensate or to make up for whatever the problem is. It's really pretty remarkable how well your body does this, but it is still temporary. And then at later stages, your signs and symptoms of your shock are going to show your signs of inadequate tissue perfusion, and we'll talk about those just a smidge more here in a minute. Okay, so when we're looking at mechanisms of shock, we're looking at the categories. We've got hypovolemic, distributive, cardiogenic, obstructive, and you'll see included in some texts as respiratory or metabolic. And so there are some specific types of shock within each of these categories, and you've got to make sure that you understand how each of them works, as well as the treatment associated with them, because the treatment for different types of shock is very, very different. So when we're looking at the three stages, we know the early signs of shock are the body's attempt to compensate for whatever the problem is. So your sympathetic nervous system stimulation is going to result in diaphoresis, which is sweating, and anxiety. Now your peripheral vasoconstriction that occurs is going to decrease perfusion to the skin. And what this does is give you pale, cool, clammy skin. It also will give you a kind of thready peripheral pulse. But the blood pressure is going to stay the same as long as you don't have significant fluid loss or significant vasodilation. Now, if the underlying problem continues, you're not going to be able to compensate anymore, and your blood pressure as well as perfusion will start to decrease. So let's look at some of the signs here and what they actually mean as far as what the shock is going on there. All right, so for anxiety, this is just a response to an epinephrine from your sympathetic nervous system, that fight or flight, and it's designed to kind of get you paying attention. All right, but that dump of epinephrine can make some people feel anxious. All right, normal blood pressure. All right, why do we have normal pressure? We've still got peripheral vasoconstriction. Okay, it's going to shunt blood away from the capillary beds, and it's going to increase the peripheral vascular resistance, and the heart rate will also increase to maintain that cardiac output. So in these initial stages, your body can different tissues have different levels of sensitivity to ischemia. So skeletal muscles may survive for a couple of hours with inadequate perfusion, but the brain and the heart can only survive a couple of minutes without adequate perfusion. So when we're shunting away here, that's what we're doing. We're taking it away from the places that can do without for a little while with a lower sensitivity and maximizing that perfusion to the tissues with greater sensitivity to maintain and keep everything going for a little while until hopefully the problem can be fixed. So our tachycardia, usually 100 to 120 beats per minute. All right, this is going to be due to decreased stimulation of the baroreceptors, and these are going to result in increased heart rate via that sympathetic nervous system. It's going to stimulate that SA node there. Okay, basically what's happening here is that we're sensing a decrease in pressure with those baroreceptors located in our vessels. So when we're looking at systemic, cardiac output, we've got stroke volume times heart rate. If we can't immediately increase that stroke volume, we're going to increase the heart rate, try to move more blood, therefore more oxygen. Right, we're going to look at the pulse quality. So if it's thready or becoming weak, this is because of that vasoconstriction. It's shunning blood away from the extremities back to the core with the lower sensitivity organs. Slight to moderate tachypnea, 20 to 30 per minute. What we're doing here is literally just trying to get more carbon dioxide out and more oxygen in. Okay, so we're just breathing faster to achieve that. Our pale, cool, moist skin, this is also due to that vasoconstriction. We're vasoconstricting because of the epinephrine and norepinephrine in the sympathetic nervous system. So we are still diverting from the non-vital to the vital areas of the body. Now when we progress to decompensated shock, whatever's going on is still happening. Basically now what's going on is your body has lost the ability to continue to compensate, hence decompensated. So you're going to start to see some progressive signs and symptoms, and depending on the patient and what type of shock and what the underlying mechanism is, they can progress to these sometimes fairly rapidly. So your signs here, altered mental status, could be agitation, it could be confusion, it could just be unresponsiveness, but this is due to poor cerebral perfusion, so hypoperfusion of the cerebral area of the brain. All right, hypotension, if our blood loss has exceeded the ability of the compensatory mechanisms, or if it's a failure of those compensatory mechanisms due to hypoxia and acidosis. All right, marked tachycardia, so greater than 120. Okay, and this, at the top ends of this, they may start to go to bradycardia. Keep in mind though, if it's coming down, are they getting better, or are they just passing through normal on the way to dead? Okay, because in order to get to zero, that heart rate's going to have to drop down first. So this is that continued response to hypotension. The bradycardia, the heart becomes hypoperfused and it's going to fail. Now our pulse quality, weak and or becoming absent. Okay, so this is a decrease in volume and a decrease in cardiac output. All right, and they call air hunger is tachypnea greater than 30 per minute. And what this is from that acidosis, your body's trying desperately to blow off excess CO2, but it's just not happening. All right, and then your skin becomes white, kind of real waxy and cold feeling. And this is absence of the peripheral perfusion, okay? And then we're not producing enough heat due to inadequate metabolism. We don't have that perfusion to the extremities to generate that heat there. So when we're looking at the phases of shock here, there's a couple of other things you need to be familiar with, and that's the ischemic phase, the stagnant phase, and the washout phase. So initially, you have all of these little capillary sphincters here, and these are just like little tightened down muscles that block and control the blood flow through these capillary beds. So initially, the precapillary sphincter and the postcapillary sphincter are going to constrict, and so this is what actually shunts that blood away from the peripheral capillary beds and redirects it to the brain, the lungs, the heart, things like that. Right? That's the ischemic phase of shock. Right? So the peripheral tissues are not receiving adequate perfusion, but they have a higher threshold, so they're okay. Now the cells of these tissues cannot participate in aerobic metabolism anymore. Okay, so energy production is reduced and lactic acid starts accumulating in the tissues. If perfusion is restored fairly quickly at this point, shock is usually going to be reversible. Okay? Now, as the problem continues and our body's compensatory mechanisms are no longer sufficient to provide perfusion to the organs, the heart rate's up, the blood volume has tried to go up, and the shock is not corrected, then the lack of energy and the decreased pH, which means more acidotic, is going to cause those precapillary sphincters to fail. So now, precapillary sphincters are open, postcapillary sphincters are still closed. So what happens is blood's going to come back in the capillary bed, but it can't move through and out because that postcapillary is still constricted. This is called the stagnant phase. And so during the stagnant phase, it's just like anything, blood, when it gets stagnant, it's going to start clumping and clotting together. Okay, so at this point, we are headed towards that decompensated shock. Now, as this tissue hypoxia continues and as this acidosis progresses, the postcapillary sphincter will fail, and this turns into the washout phase. And so what happens here is these accumulated waste and tiny little emboli or microemboli are flushed out from the capillary beds into main circulation. And so this is devastating, and this leads to even further additional tissue and organ damage. Okay, and once this critical number of cells in any organ dies, the organ fails, and it leads to irreversible shock. Now, when we have continued hypoxia and continued acidosis, the sodium-potassium pump is going to start failing in the cells. And we know when that fails, so sodium's going to accumulate in the cell, and that's going to cause a movement of water into the cell. And once this occurs, to a certain degree, your membrane's going to rupture, your cell membrane's going to rupture. Once the cells start dying, the lysosomes are going to release lysozymes, which are going to be basically self-destructing. So they're going to break down any adjacent cell membranes, and it's going to just kind of perpetuate that tissue injury and tissue death. And once enough of those cells die, that organ's going to die. And then they're in irreversible shock. And so if they don't die immediately, they usually die hours to days later. And this is where you get like your ARDS or your multiple organ dysfunction syndrome and things like that. As far as your mechanisms of shock, we've got hypovolemic, which we can further break down into hemorrhagic and non-hemorrhagic. You've got cardiogenic from several different rhythms, but at the end of the day, it's still the same thing. Your cardiogenic's pump failure. All right, your hypovolemic is going to be contents problem, so it's blood volume level. Distributive is going to be a container problem. And then obstructive, depends on which type, could be a little bit, but it's something that's blocking proper oxygenation in the body. So when we are assessing for shock, your patient in shock is going to have signs and symptoms. Early on in the process, they may be very subtle. They may not jump out and say, "Here I am, I'm shocked, look at me, this is what I'm doing." Okay, so what you have to do is know when to anticipate for shock, what to look for your early warning signs. In every single case, there's going to be some indication of hypoperfusion. It may be indirect, it may be very, very subtle. It may be something as simple as a slightly increased heart rate. Okay, but it's something to let you know that body is compensating. It's compensating and trying to maintain adequate blood pressure and perfusion. All right, you must think about shock when you're looking at differential diagnoses. Now, your obvious significant bleeding, pale mottled skin, decreased level of responsiveness, and distress are all going to, obviously contribute to your general impression of shock, but those are usually going to come a little bit later on. So what we're doing is looking for the most likely underlying cause of shock, and then we're going to determine what treatment is needed beyond that initial primary assessment. And your physical clues here are very, very important. For instance, in a hemorrhagic shock, lung sounds should be normal, but say in heart failure or cardiogenic shock, they're going to have rails, they're going to have wet crackle sounds in there. Okay, so our goal of treatment is to stop that progression towards decomp and irreversible shock. We want to stop it. If we do the wrong treatment, or if we have an inappropriate prioritization of treatments, then that treatment could be detrimental to the patient. A patient with fluid loss from vomiting and diarrhea needs volume replacement with IV fluids. But if you give that same amount of volume or fluid to a patient with hemorrhagic shock or a patient with heart failure, you could end up pushing them towards decompensated shock a lot faster. We don't want to do that. So our advanced interventions, IV, starting on IV fluids, things like that, usually going to be better off doing them during transport to prevent any delays in definitive care. But in some cases, you may want to do something while you're preparing for transport or before you prepare for transport, such as in anaphylactic shock. That dose of epinephrine is going to have an immediate positive impact on that patient's condition. That's something that does not need to wait until they get to the hospital. You need to get that in them as soon as you possibly can. Now, with these patients, it's important to realize, too, that these conditions can deteriorate very, very rapidly, so you need to make sure that you're reassessing quite frequently level of responsiveness, ABCs, oxygenation, and any interventions that you are performing here. If untreated, shock will not reverse on its own, okay? Without intervention, it will progressively deteriorate and death will eventually happen. So our best treatment is going to be recognize it and prevent it.